Good evening, everybody, and welcome to another edition of the Royal Society of Medicine's In Conversation. Now, I'm Roger Kirby, currently president of the RSM, and tonight we've got a very special guest who is one of Britain's top cardiologists, not just a cardiologist, but also a hospital administrator because he's CEO of St. Bartholomew's Hospital, Charles Knight. Professor Charles Knight OBE, I should mention. Here he is, looking very smart in his office in St. Bartholomew's Hospital. Welcome, Charles. Let's talk a little bit about your background, because I often say this is Desert Island Discs without the music. So tell us a bit about, where you went to school, where I know you went to Cambridge and then on to Oxford. So tell us a little bit about that.
Well, I grew up in Hampshire. My dad was in the Royal Navy, and my mum was in the what she described to me as the Foreign Office, but turned out on closer examination to be MI6. But she only told me that when I was 18, rather sweetly. There was a lot of doctors in the family. So my great uncle Bill was the GP for the Scilly Isles for most of his career, and probably the last proper, complete doctor that could do almost anything that there was that era. And obviously he pretty much had to do everything because getting people off the island was very difficult. He also ran a hotel, and at the age of sort of 85 was still driving a Porsche. So he was rather a hero of mine, and probably the reason I first thought about being a doctor.
Right. Bit of a multitasker like you then, Charles. Then talk a little bit about your Cambridge days. You were in the college adjacent to mine, Magdalen College, very, very smart college. What were your 3 years at Cambridge like? Do you have a nice time there?
Yeah, probably rather too nice, to be honest. I originally applied to go to Caius College, which is very much the medical college at Cambridge, on the strength of my grandmother telling me that my uncle had a glittering career there. Well, it turned out he actually got a third, and I didn't do very well in the entrance exams either. So I was fished out of what was called the pool by Magdalen, which had a reputation for land economy and rugby, and very little else. But I had a fantastic time there and did just about well enough to then move on to the John Radcliffe. That was very much a vogue of my generation. Quite a lot of us transferred from Cambridge to Oxford because Addenbrooke's at that point had very limited capacity for medical students. It was still really just starting up.
Yeah, it was weird that they took so long to develop a medical school there. But Oxford, John Radcliffe is pretty famous for its cardiology. Professor Slight, I think, was one of the leading lights there. So was it when you were a medical student you decided to be a cardiologist?
Yes, I suspect most doctors probably choose their careers on the basis of people rather than necessarily the exact things about a specialty. And yes, my first job was house officer to Professor Slight, who was absolutely wonderful man. Died very sadly, but not so sadly at a very advanced age just a few months ago. He rejoiced in the title of the Field Marshal Alexander Professor of Cardiology. He was known more colloquially as the British Airways Professor of Cardiology because he was always jetting around the world and had a particularly great reputation in the US, particularly with the ISIS trials, which were really one of the key starts to the management of myocardial infarction. When I was a medical student at the John Radcliffe, literally the treatment for a myocardial infarction was morphine, bed rest, and monitoring on the CCU. And slight work brought in the whole concept of thrombolysis. And that was an incredibly exciting thing to be actually in the hospital as those early trials were being done.
Yeah. Well, the change is absolutely dramatic. My father died age 49 from myocardial infarction in the 1960s, towards the end of the 1960s. And you know, he didn't die immediately, but he got treated very conservatively. So I'm so interested in angioplasty. We will come on to talk about that. So from Oxford as a houseman, then I know you were at St George's for a while. Was that as a consultant or as a trainee?
That was what used to be called a senior registrar. So I did a series of registrar jobs, including at St Mary's, and then there was a senior registrar rotation between the Brompton and St George's, both of whom had amazing mentors and cardiologists, Kim Fox, John Cam, Charles Pumphrey, amazing people, and I learned so much at both of those hospitals.
Who was more famous, Professor Slight or Professor Cam?
Oh, that's a close run thing, I think. Slightly different generations, but probably, I should think in the States, probably Peter Slight, probably globally, John Cam.
Yeah, interesting. And then senior registrar, you applied for a consultant job where?
I ended up at the London Chest, which was a very special and wonderful hospital in Bethnal Green by Victoria Park. Again, fantastic early mentors like Rafel Balkan and Martin Rothman. But that was part of what was then Bart's and the London NHS Trust and has now become Bart's Health NHS Trust. And the plan all along was for the London Chest to shut and for the services to be moved to Bart's once Bart's had been regenerated with the PFI, the huge PFI that took in the Royal London and Bart's and really rebuilt them at vast cost, about £1 billion.
So what year did that open then, the Bart's Cardiac Centre, which is now the biggest cardiac centre in Europe, I think?
Yes, that's right. Although to my distress, I found out, I think there might be a hospital in Turkey that is a little bit bigger cardiac centre, and it's literally 100 yards from the Bosphorus, so it's only just in Europe by a tiny fraction. But yeah, in terms of Western Europe, I think we are the largest. That opened in 2015, and that was a very long and drawn out, but ultimately very successful process of merging the services that were at Bart's, the services that were always due to transfer across from the London Chest. And then with a great leap of faith, our colleagues from the Heart Hospital, which was part of UCH, joined us in that endeavour, which was amazing amount of leadership and courage on their part, particularly from Edward Rowland, my colleague, who's medical director here. And we came together as one entity to form this very large specialised unit.
And you've got a heart attack centre there, I know, haven't you? And I mean, just talk a little bit about that, because I have a colleague, actually, he's a urologist down in Eastbourne, and he had a heart attack and got down to the cath lab within about half an hour of the chest pain, and he made an absolutely fantastic recovery as a result of that acute thrombolysis that they did from his left anterior descending branch. So just talk a little bit about how important that is and the role of Bart's, and I guess other hospitals may have the same facility in London.
So I think that the great first era of myocardial infarction treatment was the rollout of thrombolysis. And we had this whole concept of a door to needle time. In other words, the best outcomes if you have a heart attack, or to have that blockage removed from your artery as soon as possible. If it's done very quickly, you will have minimal damage to the heart muscle and have a very good prognosis. If your artery stays blocked and your heart muscle, that portion of the heart muscle, dies, you will have a shortened life expectancy, develop heart failure and multiple symptoms. Mm-hmm. So it is all about speed. And we got very good in the UK at delivering thrombolysis very fast, but it didn't work in everyone. Whereas angioplasty works in almost everyone. That is just putting a balloon in and getting rid of the clot, pushing the clot out of the way, and then putting a stent in. And if you do that early, as the example you said just a minute ago, you can really render someone's myocardial infarction an almost trivial health event. They can be in hospital for just 1 or 2 nights stay. They can sustain almost no damage. And it really is probably, as an interventional cardiologist, when I used to do procedures, I stopped about 18 months ago, but despite the toll in terms of getting up at night and doing all these emergency treatments, it is without doubt the most satisfying medical procedure that you can do. You take someone sweating, in pain, really quite distressed, put a little wire down the artery, put a balloon, put a stent. You can do that on, if it's a simple case in literally 15 or 20 minutes, and suddenly you have a pink, comfortable, happy patient. It's quite extraordinary.
Yeah, it must be very satisfying, but it also must be a bit of a staffing nightmare, because I mean, you say put a little wire in and put a little stent in, but getting that wire in the coronary ostia and then getting the wire down the left anterior descending branch is not simple, is it? It's complicated and it's tricky.
It's a huge team effort as well. I mean, I think what people really need to recognize is the huge role of the ambulance service here. I mean, almost uniquely in this country, they are the ones that do the ECG. They're the ones that diagnose the problem. And they're the ones, they don't have to call us. They don't have to, ask our permission. They bring the patients to us. And that's really a huge responsibility for them, which they discharge magnificently. And it also, when we were setting up the heart attack centres, one of the sort of difficulties is it broke a key ambulance service ethos, which is that you take the patient to the nearest place of safety. So they have to make the call to drive past potentially an A&E which isn't a heart attack centre to come to us. And that's so it's a big responsibility, and the fact that the outcomes are so good, the fact that they get it right so often, is a real testament to them. And then you've got the whole hospital team, and again, like any emergency service, you have to be prepared for days and nights where there might be 1 or 2, whereas I think when our busiest day here was close to 20. So managing a service with that degree of difference in demand is quite challenging.
And what about provision across the country? Because I can see that, within London, even within the M25, you'd be better to whiz into Barts rather than go to your local hospital. But what if you're in sort of Budley Salterton or?
Yeah, so most areas of the country will get, they all have a heart attack centre protocol. They will go to their nearest heart attack centre. Obviously, there are geographies that are more challenging. So areas, the Scottish Highlands are a very different proposition from a metropolitan area like London. London now has 6 heart attack centres spread across the capital, and that system works very, very well.
And you've got a stroke centre as well. I know that's not necessarily your specialty. I mean, you have a whole different group of subspecialists for the stroke management, yeah?
Yes, so in the UK, that's an interventional radiology procedure, and again, the stroke units have sort of followed the heart attack path. We have a very good stroke unit at the Royal London Hospital where they do thrombectomy, which is pretty much the same sort of procedure as we do on the heart arteries. It's a slightly odd situation, really. The coronary vasculature is exactly the same, really, as the head vasculature and the leg vasculature, but we come to it from different specialties. I guess ultimately it might end up more being that you're a vascular specialist, and certainly a lot of the skills are highly transferable.
And the other thing you do, the slightly controversially, I suppose, is the TAVIs, the trans-arterial valve insertion. So just give us a little update on that, because people like me, humble urologists like me, I don't know a little bit about that, but I need a bit of education on those. Where are we with TAVI as opposed to open heart surgery?
Well, I think it's fairly clear for most patients. So a TAVI is again an astonishing technical advance. If you told me when I was working for Peter Slight in Oxford that one day someone would be able to replace your valve by putting a tube in your leg, I mean, it would have been laughable. But the technology and the devices are now so streamlined that this is possible. And TAVI started off very appropriately being deployed in people who weren't fit enough to have a conventional aortic valve replacement. And there were loads of patients who you saw who were pretty fit but were of advanced age. And aortic stenosis has a terrible prognosis and terrible symptoms, and we really couldn't do anything for them before TAVI. And now those patients can be treated even in very advanced age with very good results. And again, an uncomplicated TAVI can take 20 or 30 minutes of actual operating time. It is quite astonishing. Obviously, as time goes on, the TAVI is used in progressively fitter people. And so there is that balance really between the surgeons, if you like, the gold standard aortic valve replacement and the TAVI. The TAVI is much easier on the patient, but is it as durable? And clearly, if something is more recent, then you don't have that durability data. So in many ways, this replays all the controversies and balances of risk and patient experience that go on between stenting and bypass. Is it better to have a smaller, easier procedure that might not be quite as good versus a full operation? But I think, I mean, we now do nearly 500 TAVIs a year here. We're probably one of the biggest centers in the world for that, and with really excellent results. And coming back to the Bart's Heart Center concept, that was one of our raisons d'etre. Why is a bigger unit better? Well, a bigger unit can be better because it allows more subspecialization. So you have people just doing the one procedure, and it allows more round. It allows you, for example, we have here, if you have an aortic dissection, probably the most severe cardiac complication you can have with your whole aorta ripping apart. We have an on-call surgical rotor for that. So if you need that emergency surgery, you'll meet a specialized aortic surgeon, not just a cardiac surgeon. You simply can't do that unless you have a big specialized center that can allow you to have these rotors and allow people to subspecialize.
Do you do pediatric cardiology there, or is that Great Ormond Street?
That's Great Ormond Street, and obviously that's just up the road, and it wouldn't be appropriate for us to do that. We do collaborate with Great Ormond Street a lot with the congenital heart disease, because now the results of operating on patients with even very, very tangled up hearts due to congenital abnormalities are so good that those patients are surviving into adulthood and beyond. So they need to transition to us from Great Ormond Street as they get older.
Well, topically, let's talk about the athlete's heart because of the poor footballer for Denmark, who England may be facing, I suppose, later on in the Cup Euros. Do you think that Christensen had a cardiomyopathy, a HOCM, and if he did, why wasn't that picked up on screening? Because I thought these athletes got very intensively screened for their cardiac situation.
Yeah, I mean, I should say that I obviously have no idea about what his actual history is, but I think it might well be that he doesn't have HOCM for the reason that you say, that they do have screening, and they would usually all have an echocardiogram as a minimum. and I'll just come back to that in a second. But obviously, when I was at the London Chest, we had Fabrice Muamba, who had a very similar episode with a much more prolonged recovery. So it was absolutely wonderful to see how quickly Ericsson was saved on the pitch. It was quite remarkable, and huge kudos to the early responders there. So one might well be left with a rarer type of abnormality, and unfortunately there are around the very rare edges, there are electrical problems with the heart that are there is no structural problem, there is just a genetic predisposition to arrhythmias, and they can be very hard to detect even in a comprehensive screening program. I suppose the other possibility is that very difficult differentiation, because as some people know, elite athletes' hearts are quite peculiar. Their ECGs can be quite peculiar. They can have very low heart rates. They can have multiple ectopic beats, and they can have a degree of thickening and enlargement of the heart that is solely the consequence of their extreme fitness. And delineating the difference between that and hypertrophic cardiomyopathy, well, I thank God I'm not in that field. You really, those are terrible, terrible expert calls to make, to say this is abnormal, your career is over, or this is athlete's heart, you're fine. Increasingly, we would be using cardiac magnetic resonance imaging to make those kind of calls. And usually, a really good cardiomyopathy expert would be able to differentiate athlete's heart from a cardiomyopathic process on a CMR scan. But they're terribly, terribly difficult situations.
There must be massive insurance issues. These top footballers are worth an awful lot of money, aren't they? So when they change clubs, for example, then they'll want to know that the heart is in good shape. Tricky business. Well, let's talk a little bit. We shouldn't talk all about cardiology, although I did think about doing cardiology myself rather than urology at some stage, because some of my pals went into it. But screening for cardiac conditions, obviously the potential is there, because people who have plaques in their left anterior descending branch would dearly love to know that they're there, and maybe have a sort of prophylactic angioplasty before they get a blockage. So what's the latest on that, Charles?
Yeah, I mean, it's such a simple concept as you've just expressed it, and it has so many difficult ramifications. First of all, yes, these days it is very easy for any of us to spend 10 or 15, 20 minutes in a CT scanner and emerge knowing how much atheroma we have in our coronaries. And that's something that's done probably now as the first screening test if someone has symptoms. The difficulty comes about what to do with that information, because unlike the situation with an acute heart attack or what we call an acute coronary syndrome, where we know that angioplasty undoubtedly saves lives, the situation in someone who is stable and even has chest pain, there's good evidence that angioplasty improves symptoms. But because people who have stable coronary disease rather than unstable have actually a terrifically good prognosis, it's very difficult to demonstrate any survival benefit from angioplasty, and indeed no trial has really done that. So in other words, the right thing to do to avoid coronary disease is to manage your risk factors, and if your cholesterol is high and your risk is above a threshold, to take a statin. And in many ways, knowing your anatomy and knowing what's brewing in your coronaries doesn't actually help us with that, because it's not necessarily going to lead to the need for intervention, because intervention really in stable disease is only for symptoms that are intractable to medication. And obviously doing a screening test in an asymptomatic 50-year-old man and finding a tight lesion in the middle of his LAD is a horrible situation for the patient, because they've now been told they have this thing, and it's quite a difficult situation for the cardiologist, because it's we have to explain that really there's no benefit in an asymptomatic person from having that fix. I think if I was told I had a tight lesion in my LAD, I'd probably start getting chest pains, as I'm sure we all would.
I can understand that. Well, coming on this program in a few weeks' time, we've got Lord David Pryor, and when I rang him up to ask him whether he would appear, he said, Roger, you know, the future is digi-health. Everything's going to be digital, and this wearable technology is the future. So, I mean, wearable technology like the Apple Watch and so on, looking for cardiac rhythm disturbances, I suppose, is the future. I mean, are we there now, or?
I think we're getting there. I mean, at the minute, it's sort of, you know, the cardiologist somewhat dreads the patient that says, will you have a look at these 600 downloads from my iWatch? They all tell me I've got atrial fibrillation, and most of the time it's just extra beats or something. But it is getting better so quickly that I do think that I can see a situation very soon where people with Apple Watches or devices, you know, we are going to use that for monitoring of rhythm problems rather than the Holter monitors and all the traditional stuff. So I think the rate of improvement in the technology is quite, you know, quite impressive. And you could even foresee a time where the you know, the watch will be able to do a diagnostic ECG. In other words, tell you, you know, oh, I've got a bit of pain. Look at my watch. Oh, ECG is fine. Or look, whoops, it's got ST elevation on it. I better call the doctor. So, you know, again, that would have sounded laughable 10 years ago. But I think all those things are within sight. And the other huge area is, of course, AI. And my amazing imaging colleagues here, Professor Moon, Dr. Manisty, they've done a beautiful trial looking at computer reading of cardiac magnetic resonance scan results. And actually, the AI that learns how to do it at least as good as a consultant cardiologist. And that has a huge implications across not just cardiology, but across the whole of imaging, which is particularly the rest of imaging is bedeviled by a lack of workforce. If you can have reliable AI reading of largely normal scans, then that frees up a whole lot of time for the specialists to deal just with the more problematic ones, like saying whether this footballer has hypertrophic cardiomyopathy or not.
Well, I better ask one. We've got 5 questions from Dr. Addy, who is one of our very reliable listeners and tuner-ins. Thank you, Dr. Addy. He's asking about TAVIs for mitral valves, because you mentioned it for aortic valve, but it's a bit more controversial for the mitral valve, is it?
Yeah, the mitral valve is a vastly more complex structure than the aortic valve. You'll recall that it has these cords that tether it to the left ventricular apex. It's a bigger, more complex valve. So at the minute, the percutaneous treatment that is used is something called a mitra clip, which doesn't replace or really do much to the mitral valve, but it does clip it together in the middle. And that at the minute is a treatment particularly for patients who have dilated big hearts, such that the mitral valve is pulled apart, and then you get severe mitral regurgitation usually on top of a rather diseased heart due to a cardiomyopathic process. And the mitra clip is very effective in reducing the amount of regurgitation. And that, again, can be something that really changes the game in someone who's very sick with heart failure.
One more question, Charles, and then we'll move on from cardiology. And I want to grill you about the Nightingale Hospital and about Bart's heritage and so on for another 15 minutes. I know you've got to go at 7:45. But Lisa Sachs, thank you, Lisa, for this question. Can you comment on the study that demonstrates reversal of heart disease through diet It's Dr. Ornish and the Lifestyle Heart Trial. It's in the Lancet. So you talked about statins, but what about lifestyle and heart disease?
Well, lifestyle is incredibly important. I mean, we all know the effects of exercise. We all know the effects of reduced dietary consumption of fat. Most of the evidence for diet is not so much to do with cholesterol reduction, but more the sort of Mediterranean diet that fairly conclusively is proven to reduce cardiac events, but probably by mechanisms that are different than cholesterol reduction. So in many ways, having a statin and having a Mediterranean diet are additive rather than competitive. And then obviously exercise and blood pressure reduction, you can see really important changes in left ventricular hypertrophy if you can get on top of all those lifestyle measures. So rather like the situation in diabetes, lifestyle, heart disease is more reversible than one might imagine. Having said that, there are unfortunately many patients with heart disease who, no matter how well they behave and no matter what they do, they still develop significant coronary stenosis, they still have blood pressure. And I think it's very important, really important, that people don't feel that as a result that they have failed and it's their fault. Just like any disease, it is a lot of bad luck involved as well as poor lifestyle.
And family history too, just
yeah.
It makes me paranoid because of my father that I mentioned to you. Okay, let's move away from the heart and let's talk about the Nightingale Hospital, because that must have been a major challenge, but probably loads of fun, was it? Would you describe it as fun?
Yes, it had some real highlights.
Explain exactly a little bit how it came about, because it was the emergency hospital created in the Olympic Stadium, wasn't it? So.
Yeah, in the Excel Centre in East London. And so as we were in late March, the projections of demand for intensive care were very frightening. That literally every day the ceiling on the numbers that we could expect went up and went up and went up. We have a baseline of about 800 ITU beds in London, and the weekend, I think, of Mothering Sunday, I think the 23rd of March, the modelling suggested, and it wasn't sophisticated modelling, it was simply taking the number of intensive care unit beds that were being occupied and using that rate of doubling to see where we would get to. That suggested that within about 3 or 4 weeks, we needed 7,000 ITU beds. So nearly 10 times as many as we had. And obviously each of the hospitals was scrabbling to make much more ITU capacity. And in the end, nearly doubled ITU capacity in London. So the 7,000 was not realized, but when we thought that that was going to happen, the only conceivable building that could cope with that was the Excel Centre. And so it was decided to set that up. And because it was in Bart's Health's geography, we were asked to run it as an NHS hospital. There were thoughts at the start that it might be a military operation, but then we got told to run it, and I got told to run it. And it was a time of enormous stress, enormous pressure. We didn't have the staff. And obviously people talk about let's expand beds. What we mean is let's expand staffed beds. So the only way that we coped both within the hospitals and in the Nightingale was by stretching staffing ratios. And the design of the Nightingale to some extent made that easier because it was great big long Nightingale wards. Whereas a lot of intensive cares in hospital have a certain amount of side rooms, and that means that stretching staffing ratios is very difficult. As it turned out, thank God, we only needed to admit 54 patients. So in that way, it was maybe a white elephant that we didn't need it. the thing I'm proudest about, I suppose, is that those 54 patients, when we look at them in terms of their outcome, had an exactly UK average outcome from their intensive care episode. And to do that in a few days with teams that didn't know each other in a conference centre, quite an achievement. And the clinical teams need a lot of kudos for having achieved that. I think, however, if you just look at the terrible scenes that we saw in India earlier this year, that whilst it wasn't used, the idea of having a big building with a very, very large oxygen supply was a highly appropriate insurance policy. And I'm very glad it was there. And I know one chief executive colleague of mine said, you know, whilst we were going through that first wave, and just the thought of the Nightingale being there was the only thing that let me sleep at night. And that's certainly how we viewed it. Lots and lots of learning about how to do things at pace, how to have a flatter hierarchy, more rapid decision making, lots of good things coming out of it, and a really good team spirit. But ultimately, thankfully, not used to nearly the capacity that we had originally envisaged.
I do know quite a few of our younger RSM members said to me that the training that they got in advance of going there, the team that you built up, was absolutely fantastic. They loved it, you know, because they came from all sorts of specialties apart from intensive care, and you gave them sort of, you know, rapid emergency training in intensivist medicine and so on. Just a quick call out. This is a comment, not a question, from Caroline Richardson, but I quite like it. It's just a comment rather than a question, to say how great it was to hear ambulance teams get such respect in the context of the clinical role they play in screening and referral. And I think that's right. You know, we call out the nurses, we call out the medics, but the ambulance people do a fantastic job, and we should really give them a mention, which you've already done. So I bet the politics of the Nightingale Hospital must have been interesting, but of course, medical politics are in the news at the moment, but maybe best not to go there right now. So let's talk about your role as trustee of Bart's heritage, because I was a consultant at Bart's for 10 years, and I was so proud that that hospital was established in 1123, the oldest hospital on its existing site in Europe. But I mean, that 900th anniversary is pretty special, isn't it? Tell us a little bit about that, Charles.
Yeah, I mean, it's an astonishing thing. I mean, almost nothing in human endeavor lasts 900 years, and we've been delivering healthcare free at the point of delivery for 900 years. If you think back to the Society of 1123, when most of Britain, most of the British population were serfs, essentially enslaved to their masters, the thought of an institution that provided free healthcare is truly mind-blowing. And some of the we have some of the records from the very early days. We actually have the name of patients that were treated there. And there's one guy called Alfuin who came from Suffolk with bad contractures. And what I suspect happened is that he had good physiotherapy there and regained the use of his limbs, and indeed regained his job as a carpenter. And he actually came from Dunwich, which is now under the North Sea. Because that is how old this hospital is, that one of our referral sources is now subaquatic. So it is an astonishing history, and we mean to celebrate it with as much vigor and style as we can muster. But it's also a really important opportunity to raise the profile of the hospital and to fundraise. And Bart's Heritage was set up to restore the wonderful and historic North Wing and Gatehouse at St. Bart's, which date from the 1730s, when the hospital was remodeled from a medieval cloistered type of building structure to a modern Enlightenment building, interestingly with 4 separate blocks to prevent the spread of contagion, and we could have learned a lot from that in COVID times in terms of separating buildings. So the North Wing has the most magnificent paintings, it is the most magnificent space, but since the NHS took it over, it has been maintained at the absolute bare minimum level, because the only way of spending money on it was to take money intended for patient treatment, which obviously you can't do to any great extent. So Bart's Heritage was set up as a separate charity to allow us to go out, fundraise, firstly restore the North Wing, and then bring it into a form of self-sustaining, so it can be hired for functions to allow it never to dilapidate again. COVID has also brought health and well-being of our staff to the fore, and one really exciting thing we're doing is now using the North Wing as a relaxing health and well-being hub for our staff, because the last thing we want is that precious bit of the hospital just to be an events venue. It wants to be part of the hospital, it wants to be alive, and we want to celebrate the history through the museum and use it to give our staff some downtime. So that's a really exciting project, and we're very ably led by Will Palin, who's an architectural expert who did a magnificent job of restoring the Painted Hall at Greenwich. So he's now got to make Bart's Great Hall look even better than that.
And Will Palin, son of Sir Michael Palin, appeared on our show along with Marcus Setchell just a few months ago. And yeah, good luck to you on that. Well, we've got 2 minutes left, Charles. So just before you go, what COVID and the heart? I mean, they talk about this pericarditis, myocarditis from COVID. Are your wards chock-a-block with patients affected by COVID in cardiac terms?
No, it does affect, it can affect the heart, but not in large numbers. I think if you look back to the Nightingale, one of the reasons for doing that was because we still had a mindset that was around flu epidemics, and in that sense that the intensive care usage would be for single organ failure. In other words, the lungs were shot, but everything else was fine. What we've now learned that COVID is a multi-system disease that really can affect almost any organ. There's also a big prothrombotic component to COVID, so you can have very unpleasant myocardial infarction and acute coronary syndrome, which is coronaries full of thrombus associated with COVID. But on the whole, although I think you can get pretty much any complication in any organ with COVID, the numbers with myocarditis are not big. There was a very sort of rather scary paper that emerged quite early on saying that even in mild COVID, there were detectable signs of myocardial injury, and that rung alarm bells that we might be seeing a whole load of myocardial damage down the line. Further studies have not confirmed that. That was a bit of a small study with a bit of a scary message, which hasn't thankfully proved to be the case.
Okay, so I'm going to let you go in about 30 seconds, but my last question, I ask a lot of people this question. I'm not going to ask you what you want to take to your desert island. I'm going to ask you what's your proudest achievement? I mean, you've done so much, achieved so much. What would you say was your number one achievement?
I think without doubt really creating or helping to create the Bart's Heart Centre, because it was such a slog. It was so difficult to do over so many years. And I'm proudest of the fact that the teams came together and have delivered almost everything that we hoped we would in terms of better patient outcomes, which, is not always a given that you're going to see what you expect, but they have made me very proud and have really exceeded all my expectations. So I'm very, very proud of the Bart's Heart Centre. I'm very proud of St. Bart's.
Well, on that note, we're proud of that hospital too, and good luck with the 900 year, and have a great evening. We'll let you disappear. I'm just going to make a few announcements, but you're allowed to disappear, Charles. And thank you so much So much fun to talk to you. Farewell to Charles. What we're going to do now is just give you a little reminder of some of the things that we've got coming up on RSM Live. For example, tomorrow we have a lunchtime program. Our COVID program is on vaccination in children. Very controversial issue. We've got some real experts talking about that, and opportunity for you to ask questions. And then tomorrow evening, I'm back again, and we have Jane McQuitty, wine correspondent to the Times, with David Cleave, who runs Liberty Wines, and they've selected some wonderful summer wines. I've actually tried them myself, a lovely rosé, a beautiful Albarino from South America. Really, really nice. So do join us. If you haven't registered, you can still do so. Isn't time to order the wines, but they're always so educational in terms of learning about new wines. I think a lot of people, including me, tend to go for the same old wines that we know we like, rather than venture out to different varieties. And then next week we have the 11th of our climate change series, the last but one, the penultimate climate change series, where we're talking about global planetary health. Claire Bainton, one of our trustees, is leading on that, and we have some excellent speakers. So that's on Tuesday evening. Please do sign up for that. And one of the things that we're keen on doing at the RSM is promoting action against climate change through the medical profession, and then to our patients and our friends and contacts. And then Wednesday, Simon Wesley, our immediate past president, returns to interview Tom Holland, the very well-known author, writer on classical issues. He wrote the book that I read many years ago, Rubicon, is one of my absolute favorite books. Tom's a real character. You might see him on Twitter commenting on this, that, and the other. So that's going to be a really lively In Conversation live. One or two other things to tell you. It's great to have a few minutes just to be able to give you an update. Is we are organising on the 10th of October a gala dinner at the famous River Cafe, where we've been allowed to use that on the Sunday night free of charge. So we're having a fundraising gala event there at the River Cafe, and I'm very pleased that Michael Palin, who's already had a plug this evening, is going to come and say a few words to us and help us with that evening. So put that date, 10th of October, in your diary. Tickets will be available very soon. We'll start advertising that in a few days from now. Finally, to say that we do appreciate your support watching programs like this at the RSM. We have had a very difficult year with COVID. We've lost about £4 million in revenue because our building has been closed, our bar, our restaurant, and all our lecture theatres that we normally make available to outsiders. All of that has been snookered by COVID. So if you would like to make a donation to the RSM, that will be most gratefully received. We've raised about £150,000 so far with this In Conversation series, but we do need more because of our deficit. And finally, to say that our building is now open, including our restaurant, so do come in to number 1 Wimpole Street. And if you are not a member of the RSM, we would love you to join the RSM, because it's not too expensive, roughly £500 a year for a full membership. And you get an awful lot of benefits, including access to all these webinars and use of the club and so on and so forth. So do join the RSM. Please do make a donation to our educational efforts and efforts in innovation and training of both young, middle-aged and elderly doctors, as well as the general public and other healthcare workers. So good night for tonight. I hope you will. We'll see you again for our COVID sessions tomorrow and In Conversation next Wednesday. Good evening, everybody.